Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Saswata Chatterjee, hepatologist at CMRI Hospital, Kolkata, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hi, I'm Dr. Saswata Chatterjee. I'm practicing in Kolkata. I have been doing gastrohepato practice for the last 9 odd years. I am attached presently to private sectors in Kolkata.
So, doctor, question for you is IBS really a stress disease, or is there more to the story?
Well, we can think of IBS, whether it is a stress disease or not. See, IBS occurs because of nociceptors acting in an abnormal way or normal pain sensation being perceived as greater than normal. There are non-structural issues at play more than there are structural issues at play. A part of the story of IBS always has been attributed to and will always continue to be attributed to stress. Now, stress can come in any form. It can be a mental stress, it can be a social stress, it can be a physical stress, it can be just exhaustion which is triggering an attack for all its worth. But for the major part of the story, it is such that the nerves endings which sense pain from the gut have become tuned to cause sensation of more pain with lesser amount of insult. Therefore, stress is really a part of IBS, but it is probably not the entire part of IBS. We also have seen, recent studies have shown over the last few years that there are neuronal changes or change in the nerve endings which are also occurring. Therefore, stress is a part of IBS. It is not, and it certainly cannot be the entirety of IBS.
How does modern lifestyle food habits, stress, and sleep contribute to IBS?
Well, that is a very interesting question. Modern lifestyle, food habits, stress, sleep, how do they contribute to IBS? When we look at the modern lifestyles, it's more like moving away from fruitful weekends, times to stress or to de-stress, times to reconnect socially, be calmed down mentally, to more as a hectic lifestyle, so to speak. Fast food is taking a priority because we are running short of time. We are not exercising as much as our 1 or 2 generations before, our ancestors and our forefathers used to do. We are not walking to the markets, we are taking our 2-wheelers or 4-wheelers or just ushering a cab. We are not going out to markets in certain situations, and taking, because of our shortage of time, we are unable to, and we have to take care of home delivery services. Because of our shortage of time, we are also requiring to cook food less and less and buy ready to eat meals or ready-made meals more and more. And when we do that, part of our gastronomic delights will lead to reduction in our stress form. We indulge in more calories, we indulge in more amounts of fibers, more amounts of fat, more amounts of carbs. We also indulge in certain amounts of foods such as green leafy vegetables which come as part of these food items. Therefore, all of these things taken together, the stress that we face in our day-to-day activities, the diet that we consume, which is much removed from what has been described as our traditional diet in most situations, certainly in not all, but in most situations, the lack of sleep, the urgency to get our work done in a certain time frame or in a hurry, definitely these contribute to IBS without a doubt.
How important is the patient's history compared to investigations in IBS diagnosis?
That is a very interesting question. Irritable bowel syndrome, in the diagnosis of irritable bowel syndrome, important structural causes are excluded or ruled out, and important trigger factors are tried to be identified. History taking is paramount. We must not neglect the patient's history. The person might have a definite stressor event, say, of death in the family. Beyond that, the person's problem started. A person might have migrated to a non hometown city or state for the purpose of his or her employment, or post marriage as part of his or her spouse's employment. These will typically lead to a stressor event which can cause IBS. A person might have migrated out of this country and missing his or her home so much that and the diet changed so much that the IBS symptoms which suggest IBS started. So history is important in identifying what led to IBS like problems in this person in the first place. History is also important to note what simple lifestyle changes we can implement for IBS. Sometimes a city guy has gone out to a rural center for his or her posting and is consuming water there. That might have led to altered bowel habits, mimics of IBS, but we just need to change the water source. That might be of great help to this chap. When a person is migrating, say, from a Gangetic Valley to the Himalayan regions, the water intake reduces because of cold weather, because obviously person has reduced urge to use cold water in the washroom as much as possible. And reduction in water intake and reduction in fiber intake in the food can lead to constipation. So it is important. And as we already have known from published studies, some between 15 to 25% of patients, if I had to quote a ballpark figure, would be of IBS will have features of anxiety or depression. So yes, history taking is very, very important. And also, we need to exclude certain features such as a rice based staple diet being changed over to a wheat based or gluten based staple diet, those sort of things. So, yes, history is very important.
Are there any warning signs where a physician should immediately refer to a gastroenterologist?
The question is paramount when we talk about irritable bowel syndrome, because any person who comes with problems suggestive of irritable bowel syndrome should have a little bit of diagnostic testing done. But when we decide on the timing of the diagnostic testing, that is how early we must do them or how late we might be able to do them, we talk about warning features or red flag signs. If a person has got abdominal lump formation, then even if the problem suggests IBS, we need to investigate the person early and as much as possible. If a person has got bleeding per rectum, unintentional weight loss, new onset problems, preferably say in about more than 50 years of age, if a person has got family members who suffer in the first degree relatives, preferably, who suffered from colorectal neoplasms, or if a person in an elderly age group has got relatively new onset features or new onset anemia or nocturnal sweating. These are some of the features by most and some extended criteria which are said to be danger signs or red flag signs. In these situations, a person must not be labeled as irritable bowel syndrome unless the necessary spectrum of tests have been run and all reports come as non-contributory or normal.
Once IBS is diagnosed, what is your first line approach to management?
Once a person's diagnosis has been established as irritable bowel syndrome, the first line of management is invariably symptomatic. When we talk about medicines, what I mean to say is if a person is suffering from constipation, we will give him or her medicines to relieve constipation. And when a person, on the other hand, is suffering predominantly from diarrhea predominant IBS, we will be giving him or her medicines to prevent diarrhea. Secondly, abdominal discomfort is a feature which is common across the spectrum of irritable bowel syndrome. Some people will need visceral neuromodulators. Some people will need regular medicines. Some people might need only SOS pain relieving medicines. Particularly if a person is suffering from diarrhea, we try to identify food sources which might be helpful. If we reduce them, then the diarrhea will automatically reduce. Or there are several diet charts or dietitian helps which can be taken in this aspect. When a person is having predominantly anxiety rather bothering him more than the number of defecations or the type of defecation that the person is having, we treat that. And when we have a depression, we might need to treat that as well. So to be very brief, to it is symptomatic in the first line, as the first line treatment in IBS patients.
How important is patient counseling in IBS management? What key messages do you give?
When we talk about IBS, we are talking about a disease which has its own ups and downs, which is not going to go away very soon. It is difficult to communicate such a necessity of a probable prolonged suffering, which the patient might misunderstand as a suffering when we counsel them regarding the nature of IBS. But usually, when a person has come with IBS, the faster we can reduce the person's symptoms to a reasonable extent, it's the better for the patient, because the person also gets relieved faster, develops more faith in his or her physician, and is more open to accepting statements such as the long duration of irritable bowel syndrome, the requirement of treatment which might be there for a very long time, which is not something any of us wishes to hear at the first go. But yes, it's important that we have a patient counseling done. The key messages which I would attribute to are: a, when we are talking about, say, a particular situation, say constipation predominant irritable bowel syndrome, the person is having one or two motions every week. When we give medicines, the person might not be having 7 motions per week or 1 motion per day as he or she wishes. But some people will definitely reach that level. But more practically, most patients will reach 3 or more spontaneous complete bowel motions per week. When we give the person medicines associated with reduction in trigger factors, then some residual anxiety will be there. All features such as bloating, belching might not go away as soon as the patient would want them to go away or desire them to go away. Some of these problems are going to stay. So, yes, when we give the key messages during counseling would be to try to identify the trigger factors which are important for that particular person, to try to identify the lowest number of medicines we can give once and seemingly adequate benefit has been established.
How do you balance pharmacologic and non-pharmacologic management approaches in IBS?
Pharmacological management of IBS and non-pharmacological management of IBS are not two separate compartments. They are two separate tools in our armamentarium to manage IBS, and they go hand in hand. Patient counseling, sometimes mental relaxation exercises such as yoga, deep meditation, sometimes feedback therapy, are equally important, almost as important as pharmacotherapy. It's a combination of these two which can lead to optimal benefit for the patient. Taken in isolation, without dietary advice, without advice for to control the anxiety or depression, pharmacological management will not be able to deliver optimal help for the patient. So both are important.
How do you handle a patient who doesn't believe IBS is real?
The problem with diagnosis of IBS is we have to determine a certain set of diseases or disease conditions which a person does not have in order for that person to be labeled as irritable bowel syndrome. Therefore, for a person who is having a non structural problem, such as IBS, or no significant structural issues can be demonstrated to the patient, some patients do find it difficult. Some patients are more open to accepting such sort of suggestions, some patients are not. Yes, so it is difficult to convince a certain subset of our patients who believe that they are not finding anything real. Say, a person has got normal blood reports, has got a normal ultrasound, has got a normal stool routine report, has got a normal colonoscopy and terminal ileoscopy. That person is going to believe that no real disease is being found in me, even though by all criteria concerned, the person is having an irritable bowel syndrome. So, pretty early on, preferably within the first couple of of patient doctor visits, we have to have a talk with the patient that structural problems might be there, but since we are talking about a diagnosis which is predominantly non-structural or not related to significant structural abnormalities which are attributable to the problems which this patient is facing, irritable bowel syndrome or IBS is a real disease because you are having problems. And when we give you treatments in the form of pharmacological and non pharmacological therapies, which we are giving you, you are going to see a certain expect a certain level of benefits, and since the proof of the pudding is in the eating, it will itself prove. I think it's an individualized talk, but this is how I prefer to have a talk with about this with my patients.
What are some practical ways physicians can build patient trust in IBS treatment?
It's a very practical question. A person has visited multiple physicians at multiple cities, sometimes at multiple states, and occasionally in multiple countries and continents as well, with their set of problems. So, if his or her symptoms are what is about the most bothersome issue here, if we were not to reduce the symptoms adequately, that will be a very bad initial impression, making the patient hunt around for more physicians and for separate advice. Building trust in such situations, while difficult, can be achieved by A, listening to what the patient has to say, B, if a person is certain that some medicines have not worked and we prescribe the same medicines, that might not work as well. So we need to find from what the person has not been given or at what doses the person has not been given, which may benefit this person. The questions, the cutoffs should be realistic. What I mean to say is, if a person believes that we will be able to deliver a good defecation every morning when the person is having 2 defecations per week, that is probably a bit unrealistic. We need to set our boundaries. We need to say what we can manage and what might not be coming that early and what might be a bit of residual thing. If a person is expecting to eat his favorite, say, Chinese food on the third day of starting treatment, where bloating was because of his non adherence to a previously advised low FODMAPs diet, these are some things we need to talk about. That there are certain trade offs when we treat IBS. Yes, it is going to be achieved, and yes, it's a talk which is required, and it's a practical way, and it builds trust.
One myth you'd like to bust about IBS.
Every constipated patient does not have IBS. Every patient with a diarrhea does not have IBS. If a person who is not from the medical fraternity Googles or searches with AI his or her symptoms, several of them will self-diagnose as IBS. Some of the people who have self-diagnosed themselves as IBS will eventually be diagnosed as IBS as well. However, not everybody. Say a person who has got non-celiac gluten sensitivity, an adult, will have bloating, might have stool difficulties, and might face reduction in his or her symptoms once the person has defecated. But the diagnosis here is different. The treatment approach is a bit different. Therefore, not all IBS is IBS. What the patient believes to be IBS might not be IBS. Equally, if a person is having IBS like features and physicians need to run a logical extent of tests, which have been outlined by several national and international guidance bodies, in order to be certain that we do not need to investigate this further, or the person has, for all practical reasons, irritable bowel syndromes. So, yes, all constipation and all diarrhea are not IBS. IBS is a definite disease. There might not be structural attributes which are found despite testing being done. IBS is a real disease, and all stool problems are certainly not IBS. That's a myth I would like to bust.
One word that describes a typical IBS patient journey?
It is a bit difficult to summarize or to come up with a single word which can describe a typical patient's journey. A person who is suffering from IBS has his or her ups and downs in the treatment, in the symptoms of related to irritable bowel syndrome. For some patients, it is reasonably good on most days, occasional discomforts being the norm. For some patients, on the other end of the spectrum, they will be so lucky that the problems go away with the first line of management, which does occur in several people, and they will continue to refuse to believe that IBS is real till the problem recurs. So it's relapses and remissions which are the norms. Some other less fortunate individuals will have a frustrating course. But yes, it will have its ups and downs, and most people will be doing reasonably well at the end of the day. Thank you for your attention. And if I were to summarize, irritable bowel syndrome is a disease where certain sets of tests need to be done, certain dietary restrictions need to be followed, certain ups and downs are considered part of IBS, and they are part of a journey for most patients at one point of time or another. Some people do develop depression. Some people do have depression to begin with. Some people develop anxiety. Some people have developed anxiety with the course of this disease. It's part of and parcel of irritable bowel syndrome and needs to be managed. The problems which are attributed to the diagnosis of irritable bowel syndrome are associated with defecation, and understandably the change with the pattern with the pattern of defecation changes. It's a common disease to have. It's something which is found worldwide. Simple solutions sometimes benefit majority of our patients, not everybody. There is a certain set of logically extensive tests which need to be done before a person is safely labeled as irritable bowel syndrome. It's not as frustrating as it sounds. So, thank you for your kind attention.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.